Hello and welcome to Prairie Pulse. Today on our show we have Dr. Thomas Haldis, Sanford Interventional Cardiologist, and Dr. Michael Manchak, Sanford Neurologist. Thanks for joining us today, guys.
Thank you.
As we get started, let's start off, Dr. Manchak, tell us a little bit about yourself and your background.
Yeah, I was born and raised in Denver, Colorado. Went to a little Jesuit school there in town, majored in neuroscience and biology. That was kind of my first taste of neurology, was my major. Did med school down at Tulane University in Louisiana. Started off my first year with being relocated to Houston because of Hurricane Katrina. Got through the rest of med school unscathed. Went up to Rochester, New York. That's where I did my residency, and then an additional year of stroke fellowship there.
Okay, and so how did you end up in North Dakota?
Well, you know, you start to get these emails around about your third year of residency from recruiters looking to hook you up with jobs, and there was one that was particularly persistent and seemed like she was on the ball, and I asked her, you know, to look around for a job where I would have the opportunity to build a stroke program, and there was already a really good stroke program here in place when I arrived. Dr. Kevin Faber, sleep doctor in our group, was the former medical director, and he built a great program, and we were just looking to take the next step, and so it was a great opportunity for me.
Okay. Well, Dr. Haldis, how about you?
Well, from Philadelphia originally. Sorry about my voice, I've got a little cold. But yeah, I went to medical school in Philadelphia, osteopathic school in Philadelphia, and then wound up doing residency and fellowship in Danville, Pennsylvania, a place called Geisinger. And then directly out of fellowship after my interventional year, I came directly here. So I've been here at Sanford for 12 years. Same story, was recruited out in Pennsylvania. Wound up talking to some fantastic members of the cardiology group here who were really on the ball, and I was impressed with what they had started, but mostly I wanted to go where I thought I'd be needed, and this turned out to be a good spot for me.
Okay. Well, I have to ask, since you say you got a cold, do you diagnose yourself or do you go see a doctor?
No, of course we're the worst patients.
Yes. Well, and Dr. Haldis, we'll stay with you just a minute. We're here today to talk about heart disease and strokes, of course, the specialty in each of your areas here. Dr. Haldis, with you, so what all do you treat at Sanford?
Well, I focus, the bread and butter of what I do is ischemic heart disease. So that means that I deal with heart attacks and blockages in heart arteries. As you get out into the other areas, I deal with structural heart disease, and that involves treating valves, minimally invasive valve procedures, valve replacements, minimally invasive valve repairs, closing holes in the heart. I also do work in the periphery, you know, with regard to leg blockages and neck blockages, and I also help out a little bit with the stroke program that Dr. Manchak had.
Okay. Dr. Manchak, we'll come over to you. So, yeah, what do you treat?
Right, so I specialize in stroke, and so that encompasses both the types of strokes where an artery gets blocked in the brain and the type of stroke where there's bleeding in the brain. And so I'll handle treating patients who come in with either one. About 85% of strokes are the type where an artery gets blocked, and about 15% are the type where there's bleeding in the brain, and any sort of complications or any sort of procedures that need to get done to treat these, I sort of funnel those to the appropriate skilled physicians that I work with, including Dr. Haldis.
Mm-hmm. Well, with that said, Dr. Haldis, come back to you. Talk about the advances in heart procedures over the years, 12 years here at Sanford, but you know, we always talk about advances that we have. You know, what have you seen, and then how are some of these performed, and the effectiveness of the procedures that you do?
Well, in the era of dealing with ischemic heart disease, we're talking about blockages in the heart arteries themselves. So the heart itself is a muscle. It's fed by blood vessels that are on the surface. They can become blocked, and then the muscle of that heart can then become, you know, with lack of blood flow, can die, you know, as a result of heart attack, or you can wind up having chest pain as a result of those blockages with exertion. So the drug-eluting stent over the past several years has had several iterations. So that's probably one of the bigger advances in terms of dealing with ischemic heart disease. On the structural end of the spectrum, dealing with valves that has been massive, and it has been a total game changer when it comes to dealing with people with aortic stenosis, which is a blockage of the aortic valve, and also mitral regurgitation, which is leakage of the mitral valve. Absolute game changer. So what has happened now is we have people who ordinarily were not candidates for treatment. They were either too old or too high risk for surgery. Now they are perfect candidates for this minimally invasive procedure.
Mm-hmm. Well, Dr. Manjack, so what are some of the signs of strokes, and how are they now better treated than in previous years?
So basically, we tell people anything that comes on suddenly, and sudden onset weakness on one side of the body, sudden onset of numbness on one side of the body, trouble speaking or understanding people, trouble seeing out of one or both eyes, sudden onset of feeling like you're off balance or clumsy, slurred speech, anything like that comes under the worrisome signs of a stroke. And these days, in fact, really the last 3 to 5 years, there's been a huge leap forward in terms of what we're able to offer stroke patients with a specific procedure that involves threading a catheter all the way up through one of the arteries in the leg or in the arm into the skull and physically removing the clot. This is something that we weren't able to offer patients even, like I said, just a few years back, because either we didn't have the people who were trained in it, or we didn't have the advances in the actual devices that are used to do it. But multiple trials have come out demonstrating that it's both safe and extremely effective in some cases to have folks who are trained as neurosurgeons or as neurologists who can do this procedure, or even in Dr. Haldis's case, an interventional cardiologist capable of doing this procedure, where the clot that's blocking the artery, that's starving the brain of blood and oxygen, is just taken out. And in many instances, people have immediate recovery right in the room when the procedure's done. So they go from not being able to move one side of their body or speak or see to being nearly back to normal.
Wow. Can both of you talk, and maybe is it different or not, about how time is of the essence with either, of course, a heart attack or a stroke? But Dr. Manjack, we'll go ahead and stay with you.
Well, we always quote this number to people, 2 million. It's 2 million brain cells dying every single minute in the midst of a stroke. So if patients don't recognize those signs and symptoms of a stroke that I discussed, and they don't get themselves to a hospital by calling 911 as fast as possible, a significant amount of brain tissue can be lost, and no matter what we do, it's not going to be able to take that to save that brain. So it is a very time-sensitive emergency.
Okay. So for a stroke, you're losing brain cells every minute. What about a heart issue, a heart attack?
A heart issue has similar problems. If you were to say take a coronary artery and just clamp it, and there's no other collateral supply, you've got 3 hours before it's completely dead. So you have 3 hours to do something about this blocked vessel. If, in some cases you have some collateral flow, or there's some preconditioning because there had been a tight blockage, sometimes you can buy yourself a little bit more time. But in general, we say, 3 hours is the limit that you have. When it comes to these, stroke, heart attack, and others, as time-sensitive emergencies, one of the biggest issues that we have is patient recognition, and I think this is something that you and I had talked about before. We've done very well in the state STEMI program. So that's the heart attack stroke program, or heart attack program and the stroke program around the state, in making sure that people who present to medical facilities are recognized, transported to wherever the stroke procedure or the heart attack procedure is done, and then when they get to us, the procedure is done quickly. So if you arrive at Sanford Medical Center, for example, and you have a heart attack, basically it's going to take less than an hour to have that blood vessel completely opened. You know, there's 10 minutes to do an EKG. There's strict guidelines within our facility. From that point on, they'll activate the cath team. If it's during day hours and everybody is there, you could be up in the cath lab within 10 minutes, and personally, we'll have that artery open within 15 minutes of you arriving in the cardiac catheterization lab. So that's the key point. Where we are falling down in North Dakota is with regard to patient recognition of the symptoms, and this is the most important thing. So if I can get the patient from first medical contact to the device to open up the blood vessel, and I can get that done in an hour, guess how much time it takes from the patient's symptom onset to get to the medical contact? And that's about 3.5 hours. It's way too long. So we talked about 3 hours being an important number. Most people are waiting beyond that time. And then we're just in a salvage mode when it comes to opening up the blood vessels. So really the key thing is, and the key take-home point from this meeting, I hope, is that people will learn that I need to take chest pain seriously. Any sort of chest pain, whether it's, you know, chest up into the shoulder, into the neck, something typical, something atypical, get it checked out. If you need to run to your primary care provider because you're afraid to go to the ER, then do it. But in general, our recommendation is to call 911 immediately, because in North Dakota, first medical contact equals EMS. The EMS rigs are all equipped with an EKG. They can all diagnose the bad type of heart attack that we treat emergently in the rig, in your house, in the field, in the farm, wherever you are, they can diagnose it. And then we can activate our helicopter to come and pick you up wherever you are. So that'll really trim the time down.
Yeah. Well, Dr. Aldis, one of the reasons we're probably here today is obviously I had an event on December the 11th, 2017, where I walked right out of this studio with just a little sweat at my hairline, and I just thought I was getting a fever. By the time I went 2 blocks in my truck, I thought I was going to be violently ill. Still thought I was just sick, a flu bug, a stomach bug, and by the time I went another half a mile, my neck and shoulders did start hurting. Of course, I ended up driving on home, don't live far from work, and had my wife drive me to the hospital. And you were the one that actually took care of me. And so can you talk about that procedure and maybe what I did wrong even and what I could have done better?
Okay, well, you know, first of all, yeah, I mean, had you ever had nausea like that before?
No.
Had you ever had a cold that came on all of a sudden and made you nauseated and felt like you were gonna, you know, just you know, whatever in the car? No. You didn't. So I mean, these are new symptoms for you. So people, what they need to do is they need to recognize something that is really out of the ordinary. Okay. They also need to recognize that there are lots of masqueraders, or essentially chest pain and heart pain can masquerade as other things. I mean, how many times have I heard somebody say, "Oh, you know, I had something bad to eat. I thought it was indigestion." Well, you know, if you have really bad indigestion and it doesn't go away within, you know, say an hour, you know, why not get it checked out? You know, because it could be something significant. You know, I'd expect that if I took a Tums or something after indigestion that I'd start feeling better. If I'm still feeling lousy and I'm starting to feel all this, you know, stuff like you experienced, nausea, sweating, maybe even some chest discomfort, you got to go in. You got to get checked out. So in general, the rule is call 911. And the reason being is that we can diagnose it quicker, okay? There's been a few people that have presented from a private vehicle. They mean well, they're driving on in, and then the husband has a cardiac arrest in the passenger seat. Okay, it's nearly impossible to do CPR and drive at the same time. They say don't text and drive, definitely don't do CPR and drive, okay? So just the best thing to do, honestly, is just to call 911 and get checked out in that respect, because they can diagnose it at your house.
Yeah. Well, for me, hindsight, obviously it worked out. I ended up with, you opened up a valve, not a valve,
a blood vessel,
artery for me, and put 2 stents in, and like I say, no heart damage, no other blockages. So I turned out okay, but I could have done some things different. And I did think about 911, but I just didn't know what to do. So well,
those are, you know, that's a common issue. And at the regional state STEMI conference, we were discussing just this problem, and this is going to be our next focus as the next year moves on, and that is how to increase public awareness. We've done all sorts of education. You know, it's basically, it hasn't really influenced our times from symptom onset to that first medical contact. And we talked about some of the barriers, you know, because some of the people on the board, you know, they've had heart issues. So what exactly is it? And, you know, I think a lot of those people say, hey, listen, you know, it's an expensive bill to call EMS. You know, gosh, I'm in denial. I don't want to admit that I've got a heart problem. I can tell you personally, if I have chest pain, I'm probably going to be the last one to call 911, right? But we have to understand that there's other places that you can go. You can go to your primary care physician. You can go to the urgent care center. You can, you know, we have, Sanford has walk-in clinics that will see people and diagnose these problems. So if you're afraid of that, you know, of that bill, I honestly don't want people to avoid coming for medical therapy or for evaluation because they're afraid of an ambulance bill. If that truly is the case, then you know what, fine, drive yourself if you have to. But at least get some sort of an evaluation, because it's only an EKG that you need. You only need that EKG. Once that EKG is done and you've been evaluated, then we've eliminated essentially the big one, right? And then there's some other things that we can do in the interim to sort of make sure that you're not having the medium one or the little one.
And while I didn't know what was going on, and my symptoms started about 5:15 in the afternoon as I was leaving work and going home, I guess the one thing I did right was I told my wife, get me to some help.
Yep.
And we did get there. And I literally, in my episode, it was from 5:15 until 7:30. I had 2 stents, laying in a hospital bed, watching television, thanks to the procedure that you did for me.
Yeah.
So it's important to get there quick. What about the success rates in the area, and what do you consider success? Because obviously if you wait too long, there is potential heart damage.
Well, you know, with regard to the heart, you know, the success rates in terms of doing the procedure, you know, are you know, we'll get it open. You know, it's as close to 100% as you can imagine. But you know, what is the actual effect on the heart? So I mean, if we've lost all the heart muscle and we open up the blood vessel, I mean, dead meat doesn't beat, right? So you're still stuck with you know, dead muscle in the heart if you wait too long. So that, in my mind, even though we got a good angiographic result where the blood vessel's open, you know, if the muscle isn't functioning properly, then that's not necessarily a successful outcome for our statewide STEMI program. So the real key to success is getting in quick, getting in and having some sort of reperfusion, meaning that the blood vessel has been opened soon enough to save the muscle. So if we get the muscle open, you know, under an hour, you know, you may not even have any sort of release of biomarkers, which are those special proteins that wind up getting released when heart muscle dies. You might not even be able to detect it if you get it done early enough.
Okay. Well, Dr. Manchek, what about you? What do you consider, what success rate do you have? And yeah, can you talk about that?
Yeah, so we actually, you know, a few things that I'm proud of about our program, our stroke program at Sanford Fargo. One is that nationally, only about 5% of patients are treated with a medication called TPA. That's a medication that we give in the vein. It's the clot-busting medication meant to open up a blocked artery from a clot that's blocking it and starving the brain of blood flow. 5% nationally, we treat 20% of patients with that medication. One of the benchmarks that has been set forth by American Heart, American Stroke Association for the time to treat patients with TPA is they want at least 50% of patients to be treated within 60 minutes of arrival at your facility. At Sanford Fargo, that number is 78%. They want, in best case scenario, 50%, you know, in another measure, they want 75% less than 60 and 50% less than 45, and we actually have 63% less than 45 minutes. So we're really good at getting that medication, that clot-busting medication, into people if they get there in time. So that's one thing that I'm very proud of. Another thing that I'm very proud of is that the time to do the procedure that I mentioned earlier, where a catheter is threaded up into the brain and the clot is removed, physically removed. National benchmarks want people to go from the door of the emergency room to the table to have that procedure within 90 minutes, and then from the time that the artery is accessed to the time that the artery in the brain is open in an additional 60 minutes. So you're looking at 150 minutes. That's the national benchmark that's recently come out, and we do it on average at Sanford Fargo in about 40 to 45 minutes. So we have incredibly fast times, if not the fastest in the country, for getting those blood vessels open with that procedure once the patient hits our door. But I don't consider anything a success unless the patient hits our door as quickly as possible. So just to echo what Dr. Halda said, it's about symptom recognition, it's about activating EMS. I understand that people, particularly in our region, are inclined to drive themselves because the mentality is it will take too long to call the ambulance and have them drive out and then take me to the hospital. I can get there faster by myself. And what I say to those folks is, look, you don't know what's going to happen en route. You don't know how worse you're going to get or how worse your loved one is going to get en route in your car. Plus, you don't have the advantage of having medicines on board in the ambulance to treat certain complications from a stroke. You don't have any ability to let the hospital know ahead of time that you're coming so that the stroke team there is mobilized and ready to act quickly. So the best thing that they can do is see the signs, call 911, get to the hospital with an ambulance, and then hopefully, all things go well and the patient gets there, they receive either that clot buster or that procedure or both, and they end up having little to no deficits neurologically, and they function well and they function independently when they go home.
Okay. Well, once a heart procedure is done, what typically are lifestyle changes that people have to make, and how do you direct that with patients?
Well, I generally go over some of the, I go over all the risk factors. If your blood pressure is high, you lower it. If you're diabetic, get it treated. If you have high cholesterol, lower it. You can't do anything about your family history, right? Mm-hmm. If you smoke, you really got to stop. That's the one thing I always say. I say, hey, can you help me out? Can you stop the smoking? Because that is a major risk factor. And these things are additive in a fact that it almost magnifies what your pre-risk is. Suppose you have a family history of heart disease, right? And suppose you have the little gene that that gets tickled when you smoke, and now all of a sudden there's a massive fire in your coronary arteries that leads to some blockages. So all those things play a part. Just being healthy and leading a healthy lifestyle is important. There's a thing called the metabolic syndrome that's very important, and I mean, there's so much of it out there. It's abdominal obesity, it's high triglyceride levels, and it's hyperglycemia, meaning that your blood sugar is too high. So that trifecta leads to significant issues with progression of blockages in the heart arteries, probably related to stroke as well. And those are the things that we try to reverse. And there's other things that go along with it as well. So there's such an interplay. So if you have that metabolic syndrome, you're probably also going to wind up having obstructive sleep apnea. And then if you have obstructive sleep apnea, you wind up having worse hypertension. So it's just a vicious feedback loop. So these are the things that I generally talk to the patients about and try and get them on board and help out with their own care.
Dr. Manchak, kind of go the same way. Sometimes people think a stroke, you end up with more issues than a longer road. Right. And so how do you treat that with your patients and talk to them about that and success stories you've had?
Right. So, I mean, one thing to keep in mind is that stroke does not discriminate. It affects all ages, all races, men and women. It doesn't matter. It doesn't discriminate. A lot of the risk factors that Dr. Haldas alluded to, high cholesterol, high blood pressure, smoking, diabetes, obstructive sleep apnea, those are all risk factors that are theoretically controllable in a patient population. There are some patients who don't have any of those, that are young and healthy, and maybe they have something about their blood that makes it prone to clotting. I mean, there's a lot of different things that go into why you had a stroke. And what I try to do with each patient is approach it from the standpoint of, okay, what caused your stroke? Okay, was it a heart problem? Was it a heart rhythm problem? Was it a problem because you have diseased blood vessels? What caused your stroke? And what can we do to manage everything possible to keep you from having a second one? Because in 2016, there were about 800,000 strokes in the United States, and about 200,000 of them were recurrent strokes. So we're not doing as well as we could do to keep people from having a stroke the first time, and certainly not even the second time. So we need to tailor, that's what I try to do. I try and tailor each sort of game plan to the particular patient and what they have as far as risk factors and what we need to do to keep them from ever having to show up to a hospital again with a stroke.
Yeah. Well, we've got about a minute left, guys. The time's going by quick. What's the biggest challenge with your job?
Well, the biggest challenge right now is trying to get people to recognize their symptoms early. I think if we can trim that 3 hours down, you're going to see a drastic drop in mortality in North Dakota from heart attacks. I think that's a big challenge right now, and I really appreciate you bringing this to the airwaves so we can try and educate the people in our neighborhoods, because we're all here to help out people in North Dakota. I mean, that's what this is all about, and that's why I live here. So let's see if we can make a difference here and get treated sooner.
And Dr. Banchak, your biggest challenge?
The exact same one.
Well, with that said, where's a good place to go to get more information?
For stroke, the American Heart Association, American Stroke Association has excellent website with a lot of information about risk factors, about signs and symptoms of stroke, about where to go to get stroke care, about what to talk about with your regular doctor on keeping yourself healthy and stroke-free.
Okay. Gentlemen, we're out of time. Thanks for joining us
Thank
today.
you.
Thank you.
Yep.
Well, that's all we have on Prairie Pulse this week, and as always, thanks for watching.
Funding provided by the members of Prairie Public.